welcome to the Thrive Neurosport podcast series. I'm your host, Katie Mitchell. I'm a PhD candidate, registered physiotherapist, and certified athletic therapist. And on this podcast, we'll be discussing the latest research in concussion education, management, and rehabilitation to thrive on in sport and life. I'm really excited today for episode 3 of the podcast. We have Melissa Biscardi. She's a registered nurse, osteopathic practitioner, and she's a concussion specialization. She is a clinician and also a PhD researcher working in Toronto, Ontario, and now virtually across Canada, likely due to COVID. Her educational background began in nursing in 2006. She then went on to complete studies in osteopathy and functional neurology. Melissa's passion for brain health and helping others recover from brain injury was inspired by her own brain scare in 2013, which we'll dive into a little bit. Since then, she's completed a Master's of Science at U of T in 2019, which focused on persistent symptoms in women following concussion, with a focus on reproductive health outcomes, cognition, and distress. Melissa has recently also started her PhD at U of T, where she will continue to explore concussion and interventions that improve recovery and quality of life. Welcome to the podcast, Melissa. I'm so excited. We're finally meeting virtually, which is exciting.
Thank you so much for having me. One thing I love about social media and the internet is we get to meet so many people that we may not have otherwise.
Yeah, definitely. So we connected on Instagram, just kind of as a lot of practitioners have kind of over COVID, just mutual interests and being involved in research and in concussion care. So I'd love to hear about your unique story behind your credentials and kind of your academic pathway. So if you can explain to listeners kind of how you got to where you are today and just explain sort of the different things that helped guided you.
Sure. So yes, like you mentioned, I started in nursing and I always had an interest in research from the first time I took the nursing research course. So that seed was planted. But when I graduated, I worked in reproductive medicine. So there's kind of an ebb and flow in terms of my story, but it's not linear. So after graduating, I worked in reproductive medicine clinics. So individuals undergoing, let's say, in vitro fertilization or sperm donation, situations like that. And I did that for a little while, and then I ended up working with a nurse researcher. And she was amazing. She was someone who did trials, which is really uncommon in nursing. Nurses traditionally shy away from that sort of research. So I worked under her for a while, and then it was getting to the point where you're only doing data. You're not seeing patients anymore. And I thought, oh my gosh, I need to start seeing patients again. And at that point, I met an osteopath. And I thought he was amazing. I thought, oh my gosh, I want to be like him. So I asked him one day, what do you think about me sort of changing my career path a little bit? And he said, oh, that's a great idea. So he ended up being my mentor. And I studied osteopathy and sort of started to change my path. And then in 2013 is when I had my own brain scare. And I've had concussions, but I've always had quite a smooth recovery. So my concussions were not my big scare. My big scare was in 2013, and I started to lose my memory. And it was gradual at first. So like most people, I just brushed it aside. And then it just got more and more frequent, and I was forgetting situations. I was forgetting people's names, and then forgetting people's names who I'd known for like 10 years. So for me, there were all these red flags, but it sort of became a joke to people around me, which was unsettling, right? It's just sort of not having that confirmation that something is wrong. And then one day I went into actually my mentor's treatment room, and he was treating someone, and I said, oh, I'm Melissa, nice to meet you. And the guy on the table says, are you kidding me? And it was someone I knew, like patient I had met many, many times before. And then that was sort of the last straw. And so I, of course, went to the doctor, had MRI and all this testing, but I was coming up clear. So it was just chalked up to, oh, you're stressed. It's nothing serious. But I don't know, let's say I was 30 years old. So memory loss is not normal, right? I was like, if this is how I am now, like, what am I going to be like at 50? So I just had to do my own digging. And then I figured out just by fluke that it was related to the fact that I was taking Benadryl every night. So there's a big research study that Benadryl is associated with Alzheimer's disease. And so, when they have those warning labels about over-the-counter medication, you should read them. So I was taking Benadryl every night, and Benadryl interferes with acetylcholine, which is a memory neurotransmitter. So it all made sense. I came off the Benadryl, and then slowly my memory started to come back. But the whole experience of being lost in the medical system, my experience not being validated, really opened my eyes, especially as a healthcare provider, knowing the system. Like, I knew how to work the system.
Yeah.
So how are other people experiencing their sort of health concerns? And that really had me start to dial down on brain health and an area where people are often sort of dismissed. And especially back then, like, concussion now is a what's it called? It's on the radar, but
Yeah,
brain
for
health,
sure.
right? But it wasn't back then. So yeah, so that led me to functional neurology, and sort of my clinical practice focusing more on brain health. And then I knew, well, this is a long story. So I knew that I wanted to go into research. So as I started to explore different supervisors, I met up with Dr. Angela Colantonio, who looks at brain health and women's health. And that's how I ended up in my master's thesis, which looked at persistent symptoms in women who've had a TBI. And initially it was open to all levels of TBI, but really once we started to recruit, it really was more, mild cases, but certainly not mild in symptoms.
Yeah, for sure. Do you want to explain what functional neurology is to anyone who may not understand or know what that?
Yeah, absolutely. So it's not a type of treatment, it's more a paradigm. So how
Mhm.
you approach care, and it really involves research from all areas. So I know you're a stickler on the use vision therapy, but eye movement therapy, vestibular therapy, manual therapy. A lot of people in functional neurology have a nutritional component. So I would say it's a holistic approach to care and focusing on functional outcomes, as opposed to, using medications to sort of dampen symptoms.
Right. Okay. So it kind of encompasses all those other clinical domains, including some of the other health domains. Do you find specifically that like your background in nursing plays a role in the care that you provide?
I think it set me up really well in terms of developing client relationships, like the therapeutic relationship. I definitely am a real empathetic and compassionate practitioner. And I mean, we all should be that way, but I know that is not the case. But it became easy for me once I started to transition to form those relationships and the sort of psycho emotional component of support, which I think makes a really big difference. And maybe just approaching things a little bit differently, coming from a more specific medical background as opposed to rehabilitation. Those are not the right words, but if you know
Yeah.
what I mean.
So you came in with like a different lens essentially of like
Exactly.
looking at it from, traditionally from like, other allied health practitioners. Now, your experience as especially in research, kind of like post nursing, that you worked in women's health and did some work there, is like that what kind of inspired your master's to look into reproductive health in women post injury?
So it really was kind of, I guess, serendipity because I had that experience, which wasn't on my radar, to be honest. Like, oh, I should draw in this background in reproductive health. But then when I was speaking with Dr. Cole Antonio, we realized, oh wow, this is a great. Well, first of all, it's a huge gap, but it's a great fit for me to combine the two. So it was almost meant to be.
Yeah, it's interesting. A lot of people who've been on here is kind of like it's just sort of come together. It never really was something like, you were like searching for specifically this topic. It just kind of worked out and sort of
Yeah,
fate.
absolutely.
So go through a little bit of like what your master's kind of specifically. I know it was fairly extensive, the data you collected with that. And it's pretty unique to looking at sex differences, especially with more specific hormones than kind of the traditional hormones of, estrogen, progesterone,
Mhm.
testosterone. So explain a little bit kind of like, I guess the idea behind that, and also kind of like the actual process and collecting that data and the findings.
Sure. So, and I would have started the master's in 2017. So at that point, there was even less research on women and brain injury than there is now. It was really a wide open field, and we're gaining some headway, but we still need more. So Dr. Cole Antonio had done some research looking at long-term outcomes in women following TBI and up to 10 years later. And what was coming up, and it was questionnaire based, was that women reported disruptions in their periods, they had more postpartum depression, and they were more likely to not have a pregnancy go to term. So whether that was either by choice or not by choice. So there was something there that to be explored, like what is happening with the reproductive system. And we know from other research that there are certainly hormone disruptions that can happen after a TBI. And although the research is super varied, so some research says 15%, some says 80%, depending on the sample, the timing, and the assay. But we knew we wanted to explore sort of hormone disturbances in women following a traumatic brain injury and how this relates to reproduction, or even more, does that disruption lead to a potential for early menopause? Because early menopause then sets you up for cognitive decline. So, sort of this
Okay.
snowball effect, which is kind of a far reach in some ways, but also logical in other ways, right? Just like lining up the dominoes. So, started to do the literature review in this area, and I mean, disruptions in a woman's period following a concussion. Like now it's well documented in the acute phase or the chronic phase. And there's a little bit of research that looks at, okay, is it the trauma or is it the TBI? Because just a psychological trauma can disrupt a women's cycle. But it still seems like the TBIs fare worse. So then we said, okay, well, how are we going to design this study? Because the problem with estrogen is that, well, it depends where you're measuring it during the cycle, but then also if they're on contraception or not. So that's why we were shying away from that. And then we started to look towards anti-Müllerian hormone. And anti-Müllerian hormone is a less well-known hormone. It's produced in the granulosa cells of the ovaries, and it reaches its peak around the women's 20s, so when you're the most fertile, and then it decreases with age, becoming basically non-existent around 50 when you hit menopause. So we thought this was a great marker because it doesn't respond negatively to contraceptive use. Like you can measure it no matter what. You can measure it any time of day, any time of the month, and it would indicate if these women were more likely to go into menopause early. So Any questions at this point?
No, this is incredibly interesting.
Sorry.
Like I actually hadn't really heard much about anti-Müllerian hormone, and when I read that, I was like, oh, I'm really just curious of kind of how you. But it seems like it is more of a controlled variable compared to the other sex hormones. That I know even in like exercise physiology, it's like really hard to capture the whole cycle of those hormones through, and like depending on when and like how and sort of even like different times of day and different things that can affect them. So if you can kind of get that biomarker that is consistent across the board, because I know some patients even have like IUDs or intrauterine devices that are, not just the contraceptive pill anymore. There's other things. So yeah, I'm really curious of sort of what you were there specific like a paradigm that you did, because I know you looked at the level of distress and cognition.
Yeah. So I recruited from a Toronto rehab, a clinic that saw women with persistent symptoms. So this wasn't just general population. And we recruited women under 50. And then we looked at levels of anti-Müllerian hormone compared to population norms. We looked at, there's actually a scale called the menopause rating scale, which assesses different symptoms usually present during the menopause transition. And we use the R bands, the repeatable battery for assessment of neurological status. What is that measure? Which is cognition, basically. And then we measured distress. So we measured a lot of things. Oh, and then a questionnaire that Dr. Colantonio had used in her previous research, which asked all about cycle metrics. So there were definitely a lot of interesting findings. So firstly, was it 60 or 80? 60% of the women had a change in their menstrual cycle over the last year. And 60% had amenorrhea, so loss of their period for 3 months or more. What was really interesting was the cognition piece. 50% scored like below the 40th percentile, which is super low. But then 30% were even 6% or low, which is not able to function basically in society. So there were some really extreme findings. And then when it came to the anti-Müllerian hormone levels, 40% of women were less than the norms. So, I can't say they were going to go into early menopause, but if it were me, I wouldn't want those anti-Müllerian hormone levels, right? Because they're below normal for their age. So there were definitely a lot of interesting findings. And even when I was, reviewing my thesis this morning, I thought, oh, there's just so many other research questions that can come into this, especially with like a larger sample.
Yeah, definitely. I know that you mentioned that you included all levels of TBI, and you said for the most part they were more mild or like MTBI cases. What percentage, I guess, was there any, like outliers in the sense that they were more severe brain injuries?
So it's so interesting because using the word concussion, I know, is like a big problem because people just get labeled as having a concussion. But if I were to look at these women, I would say 50% should not have been labeled concussion, just from, there were, let's say, a few motor vehicle accidents where they certainly loss of consciousness and post-traumatic amnesia. I mean, it just seemed like there wasn't a fit. But that has to do with how we label things right now, and also who's assessing them at the time.
Yeah, definitely. I think too, like depending on how long post-injury, like the changes just in the assessment measures and like robustness of kind of what we do now versus
absolutely
years ago, even like 5 years ago, is totally different. What I have found really interesting kind of in just my own experience with research is just this like heterogeneity of the sample. So like not everyone's going to present the same. Clearly, you found some, I guess, like relationships between certain metrics that you looked at. But when you said like, they experienced some change, I'm assuming those changes were like fairly variable amongst the group, and that it wasn't like everybody had the same change.
Absolutely. What was interesting was in the younger, or like I separated over 30 and under 30. So even with those divisions, it was quite different. All of the ones under 30 did not have kids. All of the ones over 30 had kids. In the women under 30, they reported a lot of musculoskeletal complaints, and that was not reported in the over 30 group. So that was interesting in and of itself. In terms of mechanism of injury, it was variable, but it really varied from a slip and hitting the back of the head to being hit with a baseball and motor vehicle accident. And I guess that goes to show you that you can have persistent symptoms from a slip and a fall or a motor vehicle accident, right? It doesn't always have to be something huge that leads to persistent symptoms.
Yeah, I was kind of just perusing through your thesis as we were talking, and I just happened to come come across the hypothalamus pituitary ovarian axis. And that to me just kind of like, jumps out, saying like a bit of autonomic influence. And you were talking about just the experience of a trauma versus the actual injury, and how much like maybe that there's, I guess a disturbance of sort of our stress response and how we respond to it. And I know that physical stress, for example, can cause like over time, like overtraining or things like that can cause like amenorrhea or different things.
Absolutely.
But I'm curious of like what, even just like your own sort of speculations of like what would be sort of, I guess, a management for this. Do you think that perhaps there could be stress management, or like, is there a nutritional component, or what kind of things would you sort of, I guess, determine as being like, how, if someone was like this in your clinic, I guess kind of putting that clinician hat, like what did that jump out at you thinking about your own patients or people that you had encountered?
Sure. So, and it's funny with head injuries because, or it's not funny, it's confusing because the symptoms are so nonspecific, right? So, even in terms of missing your periods, right? Like you said, it could be from stress, could be from the head injury, but other things like the headaches, fatigue, that could be from not getting enough sleep. It could be from stress. It could be from depression. So when someone presents with a bunch of symptoms, sort of teasing out, okay, where could this be coming from? From the Endocrine Society, they say if your periods are normal, you don't need to investigate further. But a disruption in periods, although maybe common, are a sign for investigation. When people are coming into my office, I like to work more with naturopaths because right off the bat, they will do a very thorough investigation, whereas medical doctors they're limited in how they can do things. They have to follow a process, which starts with the bird's eye view to catch like really, really red flags. So I would definitely refer to a naturopath so we can get some investigation right off the bat in terms of the reproductive hormones or cortisol, the thyroid hormones, and see, okay, where could this problem be coming from? And
definitely.
And approach it more naturally too. I'm not a medication hater, but I think if we can work on things without medications, that's great. So definitely through diet and some supplements, maybe exercise as well.
Yeah, for sure. Approaching it from that more natural perspective. And I think too, some of the medications that are prescribed end up exacerbating some symptoms that the person already experiences. And they could be like just, a normal side effect of it, but like that person doesn't need more dizziness or more of a headache or different symptoms that they get day to day. And they tend to like, not adhere to taking the medication because they feel worse and they want to feel better. So it's really interesting because I've been kind of investigating this more myself lately, of just looking into, and so that just to kind of give everybody an idea of like what the hypothalamus pituitary ovarian axis, or kind of the whole process, I guess, is associated with the autonomic response. If you could explain a little bit of how that, I guess, affects, like brings in that ovarian piece.
Oh, sure. So, but one thing I just wanted to mention in terms of medications, the other thing, and I'll ask patients when they come in if they're already on medications, well, what's your plan to get off of it? Right? Like, have they,
Yeah.
because often you're prescribed a medication without the exit plan. And I feel like most people don't want to be on medications for the rest of their life. So I think that's an important piece, that even if you choose to go down the medication route, that you should know what the long-term plan is regarding that.
Yeah, definitely. I think the right physicians who are experienced in this
Mhm.
know that it's typically a temporary prescription to just get over kind of a hump in sort of symptom exacerbation, and whether it's a sleep aid or something that's
Mhm.
a headache medication, maybe just to like kind of, or maybe it's a rescue medication. I know that
Yeah.
some people will get such severe migraines that they almost need their like rescue medication
Mhm.
just for those specific migraines, versus taking it every single day. But yeah, if
Absolutely.
yeah, so that's a very good point. I totally agree with you on that. Yeah, just getting back
To the axis. So, I froze. 1 second.
to
Are we here? Yes. Okay. Um,
sorry, did I freeze there?
you froze, but we're here.
um,
So the pituitary, sort of ovarian axis is basically the pituitary gland is in the brain, and it's called the master gland because it is a master regulator of hormones. And then our ovaries are in our stomach area. And the pituitary communicates with our ovaries and other glands in terms of function. So the pituitary will release a hormone that communicates with the ovaries, and then the ovaries really, so follicle stimulating hormone, the ovaries, and luteinizing hormone going back up to the brain. And those hormones are like an orchestra, and how they are regulated determines how we menstruate. So the theory, or one of the theories, is the concussion or head injury causes a trauma to the brain, which causes shearing forces and may actually structurally disrupt the area around the pituitary and disrupt this communication cycle, so that hormones are not necessarily getting to the ovaries and that communication pathway can't be completed.
yeah, that's really interesting. I wanted to hear that explanation just because commonly hear about the like hypothalamic pituitary adrenal axis and
Mhm.
more of just the, kind of, not sex specific, but how it responds to our levels of cortisol, and like so cortisol is kind of triggers our stress response, and over time that elevated cortisol can result in like immunosuppression and just and cause us to be more susceptible to illness and other stressors and things. So it's really interesting to hear kind of that more sex specific, and how that like the ovarian piece builds into that axis, and thinking of it as just like kind of tilting the axis a little bit and be like, it's not
Yes,
just one axis. There's probably
it's true.
multi-dimensional components to that, which I think sometimes a lot of clinicians get stuck in this really where it's just black and white, and there's just like this and this, and it's like, or it's instead of looking at it kind of more holistically, which I think you do really good job of doing.
Thank you.
Of
There was a study, another small sample study that looked at estrogen, follicle stimulating hormone, luteinizing hormone, cortisol. I think that was all. And and looking through the lens of, is it the cortisol driving the disruption? And in their sample, they did find that when the cortisol came down, that like menstruation started to regulate again. So I think that, yeah, we just need so much more research in this area.
yeah
And also there are so many factors because everyone is so different in terms of other conditions, predispositions, previous traumas in their lives. So, yes,
yeah I
looking
always
for the future.
I know. I think of the endocrine system as like this unicorn that like a lot of education programs don't speak well to, and they just don't cover it as much. Like I know in like I did athletic therapy and physiotherapy, but often we didn't hear much about the endocrine system at all. Like we covered neuroanatomy, but we did not speak of endocrinology like at all. I know other professions do more of, and I think it's kind of doing a disservice because I think it does play into a lot of how we manage individuals in particular, and that kind of therapeutic alliance of just understanding those things and understanding those effects. And I think you nailed it on the head when you said like it's really individual. Like I always think of like the individual, their context, and then like their demands, and like all those variables are always different amongst every person that comes in. So yeah, this is incredibly interesting. I'm sure there's follow-up work going on with that, building off of this.
So I know I'm supposed to probably do the follow-up to this. You know what's so interesting? So unfortunately my thesis was a small sample, but it was the first study that looked at that hormone with respect to TBI. So I feel like it should go into a PhD, but especially now post-COVID, a study with blood samples, like this, my master's was a really hard study to do. I will say, just logistically, you know how it is, research ethics, all that, like no one wants to give blood, all that sort of thing. But the other interesting thing, so my lab mate at the same time was looking at menstrual cycle at the time of injury, which we know is associated with, so that luteal phase is associated with poor outcomes, which is super interesting. And I always say women get the short end of the stick, right? Because we have so much that we have to worry about, even the time in our cycle when we get a concussion. So
yeah, for sure.
I just think the next couple of years is going to be really enlightening. And hopefully, I think actually the podcast I listened to with you touched on this. Like we have this knowledge, women are at a greater risk at certain times, so their training should be modified, right? Like we can do some really high level things in terms of managing risk. You can't take away the risk, but we certainly can try and minimize.
Yeah, even like levels of fatigue and different things. Like you're saying, like if, I know that some strength coaches will modify strength and conditioning programs based on, the cycle and just not push as hard during certain times. So yeah, it's all like, I think it's just such like you said, it's like even 3 years ago it was wide open. I think even just like right now, I was just kind of like knocking on the door and like opening it up is going to be like when, some larger sample sizes. And obviously when research and more invasive techniques can be used again, it's going to be really interesting. It's sort of like the whole world has been in sort of a halt during COVID. And that's why I don't really feel so bad about my own data collection, because everybody's kind of in the same boat. But basically when you built off of this, so you have your own clinical practice, the rehab lab in Toronto. And so you see like post-concussion, and like do you assess I'm assuming acute concussion, chronic concussion. And so obviously, like you kind of mentioned this, how, hormone therapy isn't necessarily in our wheelhouse. And it's so like, you found all these interesting things, and like, yes, you can educate and do all these really great things, but you can't necessarily intervene directly with this. So for your PhD, you've sort of taken a different direction with your focus in looking at different interventions to perhaps be more direct with your patient population.
Yeah, absolutely. So I do think this has certainly helped me become a more maybe complete practitioner, or just I really dig down into the menstrual cycle stuff, whereas I know it's sometimes brushed over. So I think patients appreciate that. And sometimes they don't realize it's connected. They got a head injury, they stopped getting their period, but they do not make the connection whatsoever. So I certainly use my knowledge in my practice and in terms of referring out. But I always knew that for my PhD, I wanted to do something more intervention based and really sort of validating some things I do in my practice. And I know there's always that question, oh, where's the research supporting this? Where's the research supporting that? And people don't realize that research comes from clinical practice, not the other way around, right?
Yeah.
Inquisitive clinicians want to validate what they're seeing. And so a lot of what I do is eye movement based, similar to you. And so that is really the direction I want my PhD to take, even though I don't necessarily think that can be standardized, but I think there are different, maybe approaches. I think there's something we can do at least to validate it. So we will see where that goes. I definitely will have a sex-based piece, though, whether it's a questionnaire to see what else changes while we do this intervention.
Yeah, for sure. That's kind of where our stuff sort of aligns well is like I do a lot right now with mainly visual perception and how it links to postural control or balance. But a lot of it comes down to like a lot of my, the background of my literature review and everything includes a ton on the visual system. And that's where I had a huge, respect for the actual visual system itself and the true components of it. That's why I say I'm a bit of a stickler on vision therapy and like what we're actually doing, because whether it's a perceptual thing or an oculomotor thing, it's a different system altogether.
Absolutely.
But I find it incredibly interesting, like, the interventions that we can do, even just linking vision to movement and vision to balance and head and neck movement. There's so many more connections than even when I started my PhD that I was even aware of, because again, we weren't taught about it. And I think just even my own reading and research has led to so many more questions. So I think that, again, this is sort of like a huge wild west of research, even though I feel like there's so much already done. There's just so many more opportunities for it.
It's also what you look for. Just like I think everyone in the world is a concussion clinician, but it's just because that's who I'm surrounded with. Yeah. I also think with the eye movements or the visual stuff, it was buried in the optometry research for so long, but now it's really coming out because the eyes are involved in everything.
Exactly. It's how we perceive the world around us. It's how we get our frame of references. Like so many variables with that. And I think once there's dysfunction in that, it creates a whole cascade of problems, not just that that of an optometry perspective. There's like ophthalmology. There's a whole there's other sectors there that I think just even my own referrals I've kind of learned through like who to send to and who like who's appropriate for what. And I'm curious, like, do you have a specific kind of like focus on what you want to look at with eye movement and in particular of anything that you've just noticed in clinic that you just like, I don't know what this is? Because sometimes I run into those questions where I'm just like, this is something that's not in a textbook anywhere. And even some of the optometrists don't know what this is. So.
Yes, absolutely. And also, so two parts. One, I want to compare to like a very basic standard sort of intervention, because also part of it is, do we need the fancy stuff, or if people do XYZ, will they get better? But I actually want to look at the basics. I would like to see if, let's say we give 3 things, if most sort of like basic eye things, if that is enough. Like, do we need to be, which probably you're like, no, it's not, but
no, not at all. I think that's
can we simplify? I mean, not for everyone, but can we simplify something? And 2 sort of outcomes. One, actual sort of stress with the eyes. Can people get back to reading the computer? And then the other, depression, anxiety. So separate outcomes, but we know that eye movements are very much involved with the frontal lobe, which is also depression, anxiety. So like just looking at those layers, right? If we do a simple intervention, like, can we really improve quality of life?
Yeah, definitely. I think when those disturbances exist, I think they factor into all of a sudden more stress, more anxiety about whether it's like a vocational thing, like can they work because of their vision issues? They facilitate all these other things that aren't directly connected, maybe to specifically the eye movements themselves. But yeah, you're right. There is a lot of connection of even just like papillary responses to the autonomic system.
Absolutely.
And like we can't always measure like the amplitude of pupil dilation or constriction, but it's just checking pupil, responsiveness, is that enough to detect something going on? I think that I'm all for like low cost, accessible interventions that more more clinicians can use. I know I promote a lot of different tech, but that's part of the objective side of me too, of like being able to actually give a number to something and connect it to a value.
For sure.
But I
That
do. Sorry, go
I was
on
just
there.
going to say, I have the goggles, like the Saccade analytic goggles for the objective eye measurements. I always do my own assessment first. And of course, the specificity of the goggles is way more, but I think we can do a lot with the low cost, right? If your eyes are trained, you can pick up on the stuff, and that's what I'm finding. So it would be amazing. Same with the intervention, like make it as accessible as possible, especially with, who knows how long we're going to be doing virtual. So
Exactly. Yeah. So you've got the do you want to explain just
oh
what
yes,
the Saccade analytics system
sure.
is for everyone?
So the Saccade analytic system, they are VR goggles that there are 6 little cameras that point to each eyeball, and it measures the eye movements and tracks it on sort of a graph, and it will show to a great precision just how far off the eye movement is to the target. And then it will test VOR, so it will look at the head movement in relation to the eye movement, and if that is coordinated well or not compared to standardized norms. And that was created by a research team out of McGill, so it's Canadian.
Yeah, honestly, there's like a plethora of
Yeah,
Canadian tech.
amazing.
We were talking about like NeuroTracker a little bit. That's out of
Yes.
Montreal. There's like I use with the FitLight system is it Aurora. It's like there's so much that actually you just on our doorstep. That's really interesting that I've seen that system. I haven't personally used it. But yeah,
I find it's a great patient education tool. So instead of me just moving my thumb around, having them track it, then I can say, look, you can't, your eye doesn't move in the upper right quadrant at all, or whatever it might
you
be.
give them a visual and the
Mhm.
feedback to say like, look at your accuracy with your eye movements and your tracking. Because typically, when you do smooth pursuits in clinic, they don't often provoke symptoms in a lot of people.
No.
Rare, like occasionally, yes, but in most people, that's like the easiest one to do. And then it's like, okay, let's go on to the harder stuff. And they often are like, oh, I can track. And then it's like they sometimes struggle, but really catching that is hard. And I emphasize the quality, like even like dry eyes, like do they have to blink? Like do they, it's just like they're
or they don't blink at all.
Yeah, or like just like
you can
observing the patient while they're doing it rather than just doing this like H pattern, being okay, that's good, check it off. I think that one would be, significantly overlooked with a lot of clinical assessments just based on like how I think that's taught. I think it's taught more to see like really gross deficits, and there isn't always a gross deficit. It can sometimes be a really like that is only finally captured in something that's more objective. Like it's basically a virtual eye tracker essentially, because we use eye tracking system in our in my lab where we can see like where basically the fovea is focusing on different targets or different things in the environment. So that is really interesting. And I've definitely wanted to get my hands on something like that too, to play with it a little bit.
If you're ever in Toronto, you come in and we'll assess you.
Yeah, I would love to be able to tinker around with different. I just like love the different tech stuff. I know it's not always like cost friendly in those senses of like purchasing all these things, but
right?
yes, I have this like affinity for it, I think, just being in research. But it would be really cool to kind of validate it against basic things that maybe like certain tweaks to assessment that could make it a much more robust objective measure. To be able to refine it for certain people, to just be like, give it a little bit more of a parameter so that it's not, I feel like nobody, like the interrelator, like, so the reliability between clinicians performing that is something that is, again, like taken for granted. I think people just do it really fast and they don't often think about really the, the distance or speed or things that they're moving. So
I totally agree.
That would be really cool. Yeah. So
with the goggles, I was just going to say for athletes, they are really helpful. I know. So since I come from a martial arts background, I have a lot of like MMA fighters coming in, not a lot, but a good amount. And I know one fighter I work with, and we found that he just had really, really poor eye tracking in that whole like bottom half of his field of vision. And I said, oh my gosh, well, we have to work on this, because if you have kicks coming up or,
Yeah.
anything coming from there, it's just your visual field is not necessarily precisely fielding that out.
Yeah, it's like capturing everything, even
Mhm.
as quickly, like you've spoken about
Absolutely.
communication issues. And I
Mhm.
often find that a lot of the dysfunction related to concussion is related to communication
Mhm.
of like whether, just in that plane, like it's not getting to the cortex fast enough to perceive it.
Exactly.
Um,
Exactly.
so that stuff is all really cool. And I find too that, again, like you take some of these things and you make it really tailored to someone that you can almost like kind of make it up as you go, because you
Mhm.
have this base knowledge in the fundamentals. And I've said this before on this podcast of like understanding the basics. And like that's kind of what you're getting to with your PhD
Mhm.
work, is like
Yeah.
understanding that stuff allows you, instead of looking at it like a checklist,
Mhm.
like looking at it from like this holistic scope and then being like, okay, this person needs to do this specific thing. This is the other symptoms they experience, and this is how I can like work with them
Tailor
to
it.
build
Yeah.
this out, rather than doing like a specific, like the one intervention that's, associated with that. It's like you can
Absolutely.
adapt those things so easily and make it really specific.
Like make the
Um,
foundation so strong and then build from there.
Exactly. And that's why a lot of the stuff I teach even is just like neuroscience.
Mhm.
It's
Yeah.
like understand the connectivity and how everything works
Absolutely.
together so that you know how to like adapt an exercise to actually engage a lot of different areas. And I think that's kind of what you're speaking to with the functional neurology piece as well. I think I've seen a few people who've taken those courses where they've really connected a lot of those things together in that integration piece.
Yeah, so I know, and even in osteopathy, they would say the same thing. If you know the anatomy, the physiology, then you know the treatment
Yeah.
almost, right? So I think that it's interesting, or speaks true, right? If you just immerse yourself in really understanding how things are working, then you can tailor how to improve something.
Exactly. And it allows you to think that like dive deeper into even
Mhm.
your like your questions and your interviewing, because I think that's where a lot, like most of our information comes from to be able to create interventions, is like,
Yes.
do we take a good enough history based on what we know about those systems? And so that's that, yeah, incredibly interesting. I'm totally into that stuff as well. um, so why don't we so your practice in
Oh yeah.
Toronto,
Sorry, I
speak
diverted.
a little bit to that. I know we could
Um,
probably go on about a bunch of other topics.
so it's in downtown Toronto. I'm a solopreneur like yourself. So I
Yeah.
work in a shared space, and I see acute concussion, chronic, like post concussion syndrome, and I do still see some body injuries, right? Just the usual sports injuries and such. And I have a approach to care involving the sort of brain based exercises, nutrition. I do make supplement recommendations usually, manual therapy, and then aerobic exercise. So using the different pillars. And then as needed, I have different practitioners that I will refer out to in the city for the team based approach, but we're not all under the same roof. And I kind of like that because I'm not limited by people who are in the same space.
Yeah, I know sometimes like if you're either directly working kind of under a practitioner,
Mhm.
then it's sort of your delegated task rather than being able to creatively work together and collaborate. Um,
Absolutely. And
I've only
versus
seen it
one
in
versus another, let's say.
Yeah, and then there's like you can kind of tailor the collaboration as well a little bit better. I've only seen a couple of situations where it's been like really collaborative with like physician-led care that's like
Mhm.
in-house, but unfortunately that isn't in every clinic. So I think that's a misunderstanding for a lot of people when they're seeking concussion care of like
Mhm.
what they're really looking for. And seeking out kind of like the unicorns like yourself that have this like extensive background in so many areas that you could
Mhm.
really help like certain cases that are, see a handful of practitioners before they reach you. I often find that where like they seek out just that general concussion certification. They
Mhm.
go to those, they
Oh,
go to a
yeah.
list of clinics, and then they go to those clinics, and eventually they're like, this isn't working. And then they end up finding someone like yourselves on, social media or just through a friend or referral. And then they're like, wow, I wish I'd come here sooner.
I know, I
um,
know.
but it is hard when we've got so many balls in the air, like you're doing a PhD, you've got
Mhm.
your practice. even just closing up your master's, like you probably just got all that stuff kind of done in the last year. So
Mhm.
there's a lot of, and
Moving parts.
yeah, and I think it's awesome though to have your hands in all of those different areas of just you're connecting the lab directly to your clinic, and that's what I've always loved to do, but it is a far stretch. It sometimes
It
spreads
is.
you really thin.
Yes.
And there's a lot of demands to that. And so when people hear about people like yourself too, especially students, like I always hope they understand that how difficult it is to actually pull off everything that like, you're doing and I'm
It's
doing. And
true.
just that it isn't as easy as it looks as like on social media sometimes. I'm
Right.
sure that, yeah, like,
No, it's so true. But I think it's so important, just like the work you're doing, mixing your, or maintaining your clinical practice and doing your research, because I know often researchers end up in the silos and they haven't seen a patient in years. And I, I don't want to be that person. I really always want to be connecting the research to the patients, making sure it's relevant, making sure I'm actually seeing human beings.
yeah, I think it's just that connection piece. I think for both of us probably is like I've never wanted to give up my clinical practice because that's where I started.
Yes.
I've always wanted to answer my questions, but I've always wanted to be able to help people directly with those answers. And I think when people get in the silos, it's usually they get like into that streamline of academia purely where it's like
Mhm.
they work on a lot more
Publish your
fundamental stuff.
perish.
Yeah, and it's more of that professorship route, which is really demanding in itself that you can't
Mm.
really maintain a practice. There's only a few people I can think of that really, have that magical role where they're like doing research for a proportion of their career and also for clinic in an institution. So,
Mhm. Yeah.
and those jobs aren't always readily available. So like sometimes you got to make it up, you make it make it work
What?
yourself. And that's kind of what I think we've done is probably creating, our own entities and working
Mhm.
within those things to have the creativity and the freedom to do the things that, we see work for people. So I think it's incredibly awesome. So I want you to just like, we're going to close things up, but
Mhm.
just, plug your clinic, your
Sure.
Instagram, social media, website, whatever you want to share of like what you're doing next.
Sure. So you can find me on Instagram at the.rehab.lab. And I like to post a lot of great things on there. Also, my website is rehablab.ca. And there's a pop up that is called Concussed Now What? And it's a, just an easy PDF you can print and put it in your first aid kit about, tips for the first 48 hours after you've had a concussion. And I think that's about it. Reach out if you have any questions about my research or anything else, and I'm happy to chat.
That's awesome. We'll share all that info in the show notes for this podcast, so you'll be able to find her Instagram handle and website there. But again, thank you so much for taking time out of your busy schedule to meet with us and do this podcast. I think it'll be really enlightening for a lot of people. So in closing, thank you for listening to the Thrive Neurosport podcast series. You can find me on Instagram at Thrive Neurosport and learn more about clinical neurosport education or CNS Ed on my website, thriveneurosport.ca. Until next time, keep thriving on, friends.
Concussion Talk podcast is presented by HeadCheck Health. HeadCheck Health bridges the gaps in concussion care through simple, powerful technology. Join organizations like the Canadian Football League, Track Factory Racing, the Canadian Junior Hockey League, Eastern Washington University, and Volleyball Canada, who rely on HeadCheck Health to improve communication and optimize care. Visit headcheckhealth.com for more. Music at the beginning of this podcast is by Ben Sound. www.bensound.com.